Hey, it's Dr. Spiegel with Plastic Surgery Secrets Talk, the podcast where we reveal the inside information that you need to know, you want to know, and you can't sort out from the barrage of information that's everywhere on websites and the internet. So this is a podcast where we're talking with the experts, getting the actual things that they know and cutting through all of the fog. I'm very, very happy today to be speaking with Dr. Guy Massry from Beverly Hills, a super renowned, respected oculoplastic surgeon specializing in all things around the eyelids and eyebrows, who is always kind with his information and knowledge at lectures and meetings. So Guy, thanks for speaking with us today.
Thank you for having me here.
Okay, so you said something very provocative to me a minute ago, which is you said right before we started recording that brow lifting is a terrible term.
I think brow lifting is the worst term that we use in aesthetic medicine.
Wow. Okay, tell me, what is that?
We have scared people to the point where they will walk out of the office sometimes when they hear the term. Why is that? We know that with natural aging, things descend in a certain way, and we know if we lift them, we should lift them in a certain way. But the vector, the direction that we have traditionally lifted the eyebrows is very vertical. It's like when you lift up your forehead, you activate your frontalis
and you look surprised as you do that.
So patients come into the office, the second you mention brow lift, they go, I'm going to look surprised, I'm scared. I'm going to have big scars, I'm going to lose hair, I'm going to have pain, I'm going to be very, very numb. But that's because traditional brow lifting, those complications have been significant. What we don't understand is where we are today with brow lifting, it's not about height, it's about shape, arch, and contour. And
looking natural.
And if you focus on shape, arch, and contour and explain that to patients and show them those pictures, they're extremely satisfied. And I have a rule. It's called Massry's 90-90 rule.
Okay.
90% of people that come into my office ask for their upper lids to be improved. They blepharoplasty. And 90% of them, I believe, need to have some kind of change in the shape, arch, and contour of the brow. So it's my job to make brows less scary, unscare it, re-educate, and let them know the importance of it.
So the 90% who need something done to their eyebrows, what percent of that 90 also needs something done to their eyelids?
Almost 100%. It's rare to do a solitary brow lift. The brow and lids are in a continuum, and you have to do a little to both rather than too much to one.
Absolutely. Absolutely. So what is the method of brow lifting that you would recommend for someone who's never had surgery, the most common, most typical thing?
I would say that 70% of my patients have what I call a temple lift or brow recontour, where the outer part of the brow is adjusted to a certain degree, and about 30% have the central area adjusted too, but not in a vertical lift. It's still in a up and out lift, a supratemporal direction, and that way they don't look surprised. And I don't mess with the muscles in the glabellar area between the eyebrows, because when you do that, leads to a whole slew of other issues.
Oh, absolutely. Messing with the muscles, you're going to get unnatural muscle motion when they start to heal. Absolutely.
And
hollowing.
Displays and all this. You know, we have Botox, which is an unbelievable tool after brow
Absolutely
lifting.
Right.
And I've looked at patients that had brow lifting done, and if they were kept on a regimen of using Botox to help maintain their brow position over a 5-year period compared to those that didn't, it's night and day different. A brow lift is a rejuvenative procedure. It's something to make you look better, but it does need to be maintained because the techniques we have to grossly disturb the forehead and brow architecture make people look weird.
Yeah, and all those muscles that you're able to relax and attenuate with the Botox, those muscles are pulling in directions that are against what you want, right? The central muscles with those 11s are pulling inward, and that's depressing that medial brow, like you said. And when you pull up and out, you're relaxing that area and going back to before that muscle overcompensated.
So the problem is, historically, the way we dealt with it, we would extirpate those muscles. But surgery is supposed to be about being anatomic. Those muscles are there for a reason. We take them out, there'll be a price to pay for that too.
Anatomic is the best word, and that's one of the things, like I always rail against that with people who come in with fat grafting to areas where it should have been a bone graft or things like that. You have to put the right structure and the right tissue where it belongs.
Absolutely.
Okay, now talk to me about filler in the upper eyelids. or volume loss and A-frame deformities when you start to look too hollow. What do we do about that?
So it's interesting because I'm not against fillers. However, fillers are a very bioactive material. They bind 1,000 times their weight in water. And the issue I have with fillers in the periocular region, really more in the lower than the upper lids, is that I think that over time, almost 100% of people with repeated injections will develop what I call blue dyschromia. I don't use the word Tyndall effect because scientifically it's wrong, and also chronic swelling. And there are changes that occur in tissue that are inevitable and you can't get around. And I do a lot of surgery on patients that have had fillers placed in the upper and the lower lids, and I can tell you that the tissue, the integrity of the tissue is different. Fat becomes fibrotic, scarred, engorged, they heal differently. It's a very different process. So if you were to ask me, if you can become proficient at injecting autologous tissue such as fat and do it in an appropriate way, I think long-term you're better off, little bits at a time. You can also transpose fat in the upper lid. We've published a lot on that to get the contours that you want. I think, you know what I look at it as this. When you're building a house, you build a foundation. That's the fat, that's the implants. You know what fillers are? A little bit of touch-up paint here and there.
That's
but
right.
We use them as a foundation. That's a problem. They weren't meant to be used that way.
Absolutely right. Fillers are a maintenance product, and again, if your house is falling apart, you need some real construction, and then you're going to need the maintenance too, and you just can't do it the other way. You don't want to paint over a structural problem. Absolutely right. Excellent. Okay, so now let's talk about the fat grafting for a second. Where do you like to get this fat?
So all studies have shown it doesn't really matter where it comes from. I'm not sure even it matters how you process it. I do think how you harvest it, the cannula you use, the technique you use, how much suction you use is important. But I've usually on the table when someone's in a supine position, if I can get something from the belly or the love handles or the inner thighs, that's the easiest thing to do. But I can manipulate a patient in any direction and get it from wherever they want me to take it.
The biggest complaint I get from people who need fat grafting to the face or the eyelids is that I didn't take out enough fat from the site where they're harvesting.
Yeah.
Everyone wants more out and less
I do
in.
explain it's not a liposuction procedure.
Exactly. That's a very good point. Okay, and then one other thing on lower eyelids quickly. How often with fat grafting are you seeing fluctuations where it goes up and down with the person's weight?
So I think you're going to see that much more in the face than you will in the lids because the amount you're putting in is so small. So long term, I've seen a lot of people that gained weight. Remember, the fat comes from belly, we gain weight. As we get older, that tends to get larger, and I've seen it in the face. But usually people that have had 30, 40, 50 cc's injected, what you put around the eyelid is small, and I haven't seen that so much. What I have seen, it's really interesting to bring it up, we just published a paper in ASJ. What I have seen is how to treat the lumps, bumps, and contour irregularities you get from injecting fat around the eyelids, which is a very delicate area. And we've come up with a transconjunctival way of excising them with a very, very high success and satisfaction rate, which is weird because you'd think it wouldn't be because this fat we found out was always embedded within the orbicularis muscle. You have to traumatize it, but they do well for whatever reason.
That's fabulous.
Yeah.
So if you're able to pop those little, or not the little ones, you're taking out the larger balls of fat, the ones that are causing the problems.
So we have classified into diffuse enlargement, solitary nodules, a mixed picture. We have all kinds of classifications for this now.
Okay. What is the one thing, if there is something, that a person could do to avoid the need for our services, for brow lift and blepharoplasty moving forward?
You know, I think that as we age, probably the biggest thing I see that happens when we get into our 50s and 60s is what we've done to our skin from environmental factors, etc. I think we can't do much about the loss of volume, which caused things to descend, and then the tissue drop. I think if you do good skincare, have a healthy diet, take care of yourself, and I'm a big, big proponent of maintaining a healthy lifestyle in terms of what you do physically and keeping weight off. I think that there are humoral factors, and this is being studied now, that are released systemically that help maintain a bit more of a youthful appearance. And I think that right now we're doing so much surgery to compensate for other things. Hopefully this all melds together and the pot becomes a little clearer as time goes on.
And sunglasses?
Oh, sunglasses are important for so many reasons.
See that? Okay.
Yeah.
Not only do they make you look sharp, they're going to keep you looking sharp for longer. Thank you so much, Dr. Massry. You've been listening to Plastic Surgery Secrets Talk. If you liked what you were hearing, you can download more of our podcasts anywhere you get podcasts. And if you want to reach Dr. Massry, how do we do that?
You can reach me in my office in Beverly Hills, 310-657-4302.
And how about online?
Online, it's drmassry.com.
With 2 S's in Massry, not 1. And of course, questions for us, you can reach us at Dr. Spiegel at DrSpiegel. We'll see you for the next episode from sunny Miami.